I'm going to formally introduce Dr. Tran. Henry Tran is a cardiologist. He's a board certified cardiologist, and he's board certified in cardiovascular disease and echocardiography. He has 18 years of experience and practices in both the Inova Cardiology Fairfax office, which is at the Inova Specialty Center, directly across the street from Inova Fairfax Hospital. And he also practices at the Inova Cardiology Fair Oaks office, which is adjacent to Fair Oaks Hospital. He has a special interest in management of coronary artery disease, valvular heart disease, sports cardiology, and hyperlipidemia. Dr. Tran serves as the medical director for Inova Cardiology, which is a practice with 9 locations and over 45 cardiologists that are located across Northern Virginia. He's also the associate program director for Inova Heart and Vascular Institute's Cardiovascular Disease Fellowship Program, and is also an assistant professor of medical education for the University of Virginia. His dedication to medical education has been recognized with several teaching awards from the Department of Medicine. So with that, Dr. Tran, thank you for your time tonight, and the floor is yours.
Absolutely. Thank you, Mona, for that great introduction. I appreciate being invited to speak to you all tonight. So thanks, Champa and Mona, for your help with this. So, staring out into the Zoom ether, I can see 19 people are here, and I hope tonight we can answer some of your questions and you can walk away knowing a little bit more about hypertension and how to treat it effectively. I have just a few slides to just kind of go over some high-level things, and then we'll turn it over for your questions and we can dive into it. So I'm going to share my screen here, and hopefully, can everyone see this? Just Mona, can you confirm seeing this then?
Yes, I can see
great.
it.
Okay, excellent. This is some older data, but it still holds true. High blood pressure is extremely common. As you can see in this slide, this is NHANES. This is a national survey that surveys Americans from across the country. And what they found is, we estimate somewhere between 65 to 85% of Americans above the age of 50 have high blood pressure. And of those people that do have high blood pressure, only about 80% of them are aware of that. And then slightly less are treated. And then unfortunately, as you can see, for the total population, Caucasians, African Americans, and Latinos, that less than half of people who have high blood pressure are actually controlled. And I think in medicine, one of the biggest things that we are challenged with, how do we improve our treatment of high blood pressure, because it's so important. And things like tonight is really essential to that mission, because it's education. It's for people to recognize high blood pressure when it does occur, for people to prioritize treating high blood pressure, and to really have a great relationship with their primary care doctor, or maybe sometimes a cardiologist, to find the right treatments to get their blood pressure controlled without side effects. So just to highlight, where a lot of the people are across the country, and hopefully many of you are in this aware category and adequately treated and controlled. And just to highlight some small things that we feel that even small reductions in blood pressure, just even on average 2 millimeters of mercury systolic, can actually decrease your cardiovascular risk by up to 10%. And we've seen that blood pressure treatment in general is associated with significant reductions in stroke, reductions in heart attack, which is this myocardial infarction, and then more than 50% reduction in heart failure. And another area that we now know that there's always been a long-standing association between dementia and Alzheimer's and high blood pressure. Of course, most people end up getting dementia when they're an older age. Most Alzheimer patients are in their 7th or 8th decade of life, and of course the incidence of high blood pressure goes up as you get older too. But beyond that, we do see a strong association. And what more and more studies lately have shown is that if you treat high blood pressure and you treat it well earlier, you actually can reduce the risk of Alzheimer dementia or just general vascular dementia as well. And then not only is it protecting dementia, but also makes you live longer. And this is a very important study that came out several years ago. This was a national study sponsored by the NIH called the SPRINT study. And the SPRINT trial in particular looked at comparing different targets. And the question they're asking, like, if we reduce blood pressure on average from systolic 140, which is what many people use still, and we push it down to less than 120 on average, do we get any benefit? And surprisingly, the study showed that there was a benefit in the composite of all your vascular problems, heart attacks, strokes, heart failure, and dying from heart disease. And as you can see in this plot here, over 5 years, the standard group was in gray. The standard group's in orange. And this group was compared to the intensive treatment group, which is here in the gray line. And after 5 years, the intensive treatment group, again, with a blood pressure reduction to on average to 120, saw about a 25% reduction in the overall composite of all this heart disease and vascular disease. And then another number in medicine we calculate is the number needed to treat. So we look at the treatment effect and we determine, well, how many people actually need to get this treatment for us to see this result? And we saw that number needs to treat was 61 patients would have to be treated for 3 years to have one person suffer one less event here, which is actually in medicine a pretty significant effect. But more startlingly is the primary outcome was looking at all-cause death, meaning do people live longer with better blood pressure control? And the answer to that was yes in this study. So again, the same study looking at the number of deaths, there was 365 total deaths. There was less deaths in the intensive treatment group, 155, and 210 in the standard group. Sorry. So again, the standard group here is in orange, and you're comparing that over 5 years to the intensive treatment, and there was about a 27% reduction in death. And that separation started about 2 years. So after 2 years of treatment, you started seeing the intensive treatment actually do better than the standard treatment group. And so basically the number need to treat, meaning how many people do you need to treat with more intensive blood pressure to save one life, was about 90 people based on this study. And this study was very impactful, and what cardiologists and primary care doctors and the medical field uses are these national guidelines that are written by the ACC, which is American College of Cardiology, and they're co-written with American Heart Association, the AHA. And based on the SPRINT study, they actually redefined the goals of treatment. And they're saying basically for all people with heart disease, with heart failure, even with diabetes, chronic kidney disease, that we should really be treating people to less than 130 over 80. Now, this is a controversial recommendation, and we can certainly talk about it in the Q&A because not everyone agrees with it. To be honest, I don't agree with it on every patient either. But I think in concept, it highlights that if you can aggressively control blood pressure and not suffer any side effects from that, there's actually a lot to gain from this. So moving on, one thing I'd like to highlight and make sure everyone knows is how to check your blood pressure at home, because many people don't do it correctly. And I try to spend time in my clinic visits going over correct blood pressure control with people. And the key is, and this is summarized in this nice little cartoon by the American Heart Association, that you need to be seated in a comfortable chair for about 5 minutes before you check the blood pressure. A lot of my patients, I think what they end up doing is they do an activity, then they come home, they may go upstairs, grab the machine, come right back down and start checking it. And if you do that kind of level of exertion, especially going up and down stairs, actually does raise your blood pressure, which leads to measurement error. So really, it's important for you to be seated for 5 minutes, we'll say 3 to 5 minutes even, to achieve a resting state, okay? And have the arm resting on a desk or a table. And then using an automatic blood pressure cuff, check the blood pressure. And it's important to check it more than just once. And we recommend people check it 2, if not 3 times, waiting 1 minute apart. And so you get ideally 3 measurements, and then you average the last 2 measurements that you take. And if you take 3 blood pressure measurements, many times what you'll see is the first set is high or higher, and the second and third are a bit lower and closer together. And so that's a very common effect. And so that's why if you do track your blood pressures at home, you should be doing it correctly. And so this is not a quick methodology, right? Because it could take up to 8 minutes to check your blood pressure. You have 5 minutes of rest. You're checking it 3 times with 1 minute apart. It can take a while. And depending on your machine, some machines, there's a function, for instance, Omron is a great company that makes blood pressure devices. There's a setting that the machine automatically will do 3 in a row and won't even show you the blood pressure number until it has 3 measurements in a row. So just want to highlight that. Um, and last but not least, I just want to make sure everyone understands there's basically 4 types of people in the world when we look at it from the lens of hypertension. That the first type is normal tensive, meaning you don't have high blood pressure at home or in the office. Okay. The second type is a sustained hypertensive, meaning you have high blood pressure at home and you have high blood pressure in the office when you come see the doctor as well. The third type is the white coat hypertension, which I suspect a few of you may. It's about 30 to 40% of our patients have white coat hypertension. So whenever they see this, the blood pressure rises, meaning the blood pressures are high in the office and lower at home. And I have many patients that they check their blood pressures at home all the time and it's very well controlled. But when they come to see me, it's like 20, 30 points higher. And it's important that I adjust the medications not based upon the blood pressures in the office, but based upon the blood pressure measurements at home. So that's called white coat hypertension. That's a significant portion of the population fits into that. And then the fourth type is called your masked hypertensive, which is the exact opposite of your white coat, meaning their blood pressure is normal in the doctor's office, but high at home, right? So every time they come to the doctor, it's fine, but for whatever reason, it's only fine in the office, and at home, it's actually higher. And when you look at the outcomes, the health outcomes of people with masked hypertension, they are equivalent to those people with sustained hypertension, those with high blood pressure all the time. So anyways, I think these are the basic slides, and hopefully this is a starting point for us to have a good discussion. So I'm going to stop sharing my screen now, and then maybe I'll let Mona kind of answer some questions in the chat.
Okay, actually, there are a couple of questions. We had one that came in even before the session started. It's a great question. It says, I understand that it's important to control blood pressure. However, it seems that while blood pressure medication might bring down the rate of blood pressure, it seems odd to me that there is so much emphasis on medications and not the cause of the rise in blood pressure. For
Yeah.
surely there must be a cause.
That's a great question. To be honest, sometimes there's a cause, but many times there's not. And what we've seen as we kind of get into, a modern industrial westernized diet, which unfortunately is higher in salt and higher in processed foods, that the incidence of blood pressure does go up. And so is it related to diet? Yeah, probably. There are probably a lot of people who are salt sensitive. And I think before anyone starts blood pressure treatment, there should be a period of time where you work on lifestyle. Because I want to emphasize this, that adequate treatment of blood pressure is not only treating with medications. Medications is part of it. It is in conjunction with lifestyle changes, right? So someone's high blood pressure, that person should have a low salt diet, less than a teaspoon of sodium a day, which is about 1,500 milligrams of sodium. You should be exercising, 20 to 30 minutes every day. I say every day, and then they should be sleeping well. If they snore, they should be having a sleep study, and maybe you need a CPAP machine for treating a sleep apnea. So I think to your point, I think in most people, those lifestyle changes are done in conjunction with blood pressure medications and not instead of blood pressure medications. Now, if someone has blood pressure at a young age, like when we encounter someone like 18, 20, 30 years old, and they have high blood pressure, we definitely do additional studies to make sure they don't have a secondary cause, meaning they don't have another disease process that's actually causing their blood pressure. And that a lot of the time it has to do with the kidneys. So we make sure there's no kidney blockages. We make sure the kidneys are working well with blood tests and urine tests. There are some hormonal imbalances with something called aldosterone or with adrenaline, something called pheochromocytomas that we rarely can see. So to your point, I mean, I think if it's a young person, we definitely look very aggressively into identifying other disease states that may be causing this odd early high blood pressure. But if someone is middle age or older in their 60s and now developing blood pressure, many times it's just due to aging and diet, and changing the diet is easier than changing the age. Um, but if the lifestyle changes don't work, then people do need to take blood pressure meds. And what I also tell my patients too is, like, if they're overweight and they really haven't gotten their diet in order, sometimes I say, listen, let's just treat your blood pressure now. If you're able to exercise and lose a lot of weight and your blood pressure comes down, then we'll trim off the medications, right? We can at least control your blood pressure in the meantime. And as you get your lifestyle in order and your blood pressure drops further and further, then we can either decrease medications or take you off sometimes. So sometimes we can adopt that approach. So that's a great question. Should always think about lifestyle modifications.
Okay. I think you actually answered another question that has been put up there, which was why does, well, you touched on it. Why does your blood pressure increase as you age?
Yeah. Yeah. So again, we see it, and back in the 40s and 50s, when they saw blood pressure rise in older age, that's where this term called essential hypertension came about. And the early theories was that as you got older and maybe your, arteries got a little stiffer, that the high blood pressure was a compensatory mechanism, that your body was needed have a higher blood pressure to perfuse your brain, to get into your blood and your heart and whatnot. Um, there was a famous study called the Hydralazine study that treated high blood pressure in 80-year-olds, in very advanced older people, and actually treating blood pressure even in those people, we saw benefits in lower heart failure and lower stroke and heart attacks. So this concept that older people can have high blood pressure and that's normal is definitely wrong. You definitely need lower blood pressure. I think what still is controversial is, like, well, do you bring someone down to 150? Do you bring down someone to 140, or take their systolic blood pressure down to 130? That is still somewhat of a controversial topic. The guidelines in Europe, for instance, say that, if you're over age 70, you're allowed to have another 10 points of blood pressure elevation. You don't need to get it down to 130. So in terms of is having high blood pressure in older age completely normal? No. It should be treated. So good question. Thank you.
Okay. And there was another question I think that you've partially addressed. They were asking if the blood pressure goal should be different for somebody who is 65, who's on blood pressure medicine. And is there a difference for men and women in terms of the blood pressure guidelines?
Yeah. So I'll take the first answer. So, if someone's over 65, like, that's still on the younger side of, senior citizen. So I still try to take all my patients down to 140. And then if we can get their blood pressure lower with only a couple of drugs or 3 drugs, then sometimes I do recommend taking the blood pressure down to 130. It's somewhat of a individual decision. And if the person has, for instance, diabetes, and they're at really high risk of heart disease because their sugars aren't really well controlled, they're really overweight, they're on insulin, then that's someone that the American Diabetes Association guidelines do recommend we be further aggressive with the blood pressure and try to get it down to 130. And then the second question, I think you asked about the gender. There are differences between men and women. There aren't. So as of now, both men and women have the same blood pressure targets.
Okay.
Yeah.
And so another question that's showing is, when should someone see a cardiologist about blood pressure? And I'm going to expand that of if you've been seeing your primary care doctor, and maybe you can address like when is it the point where you should consider a cardiologist?
Yeah, I think you should discuss that with your primary care doctor. I mean, I don't think everybody with high blood pressure needs to be seen by a cardiologist. I think for sure, if you're having trouble controlling the blood pressure, something we call resistant hypertension, then that's something a cardiologist should get involved with. So if you're on 4 drugs and it's just not controlling it well, for sure you should see a cardiologist. But if you're exercising and you're on only 1 or 2 medications and your blood pressure is really well controlled with that, no, I don't think you need to see a cardiologist just for that. And then on a separate topic, people ask about getting screened for heart disease. And I think traditionally people think the best test has been a treadmill where you kind of do an exercise stress test. But more and more people, the studies are showing that something called a coronary calcium score is more accurate. So if you have an intermediate risk of heart disease, let's say you're 65 and you have high blood pressure and your LDL cholesterol is a little bit above average, like 120s, then I think you should be screened for coronary disease with a CT calcium score. And if you are elevated, meaning you have more calcification than normal, then you should be treated with a statin, something such as Lipitor or Zocor. But really, you don't need to see a cardiologist just because you have high blood pressure.
Okay. And here's a question about what is the best device to track your blood pressure? And can you use an oximeter to do that?
Yeah. So an oximeter is something that you put on your finger and it measures your oxygen levels based on your blood. Basically, there's a light diode that sends out a specific wavelength, and it can see how much light is absorbed. And the more hemoglobin you have in your blood with oxygen, the less light is absorbed. So based on that, the computer can calculate your oxygen levels. So that oximeter just measures your oxygen levels. It can measure your heart rate. It can measure your pulse, but it cannot measure blood pressure. So the best device to measure your blood pressure is an automatic blood pressure cuff, and it sits up here. There definitely are devices that sit on the wrist, but we find that those are less accurate and there tends to have more variation. So try to buy an upper arm cuff. Make sure the cuff is the right size. Many people, especially overweight people, can have bigger arms. And so if you just buy the regular size cuff, it doesn't sit correctly on the arm, and that can lead to higher blood pressures than reality. So you want to make sure that if you're a bigger person that you buy a bigger cuff. Vice versa, there are some people as they age, the arms do get smaller. Have a lot of nice patients that, the arms are, just a few inches wide and they need to use a juvenile cuff. All right. And so a pediatric cuff. And so it could go both ways. But you want to make sure the cuff sits correctly. And then again, you want to make sure you sit down for 5 minutes before you measure. And interesting enough, the machines measure your blood pressure looking at the pulsations that come through. There's no sound detection because the traditional, excuse me, the traditional method of measuring blood pressure is manually with a stethoscope, and you're listening for the heart sounds to come through as you release the blood pressure cuff. The automatic cuffs use a different algorithm. It measures the pressure waves that come through it, and it doesn't measure the sound actually. And based upon that, it derives your systolic, which is the top number, and the diastolic, which is the bottom number. Each company has a kind of a slightly different algorithm. It's sort of their secret sauce. But all devices have to be vetted by the FDA before they get approved on the market. So even though the companies vary a little bit in their technology, they all have to be FDA approved before they can be sold. So, another useful feature, especially with people who are a little bit more technologically inclined, is Bluetooth connectivity. So Omron, for instance, they have an app on your smartphone. And so every time you check the blood pressure, it automatically goes to your app, and then you can send your numbers to your physician to review. And I find that useful instead of having people type it into a spreadsheet. So, that's a slightly nice feature, but certainly not mandatory. Automatic blood pressure cuffs are not expensive anymore. If you belong to Costco sells a great model. I think I saw it for like $38. So I think, it's a worthwhile medical device to have at home, and make sure you use it. Now, as is sometimes people will be instructed by their physicians to check their blood pressure, and they ask how to do it. If your doctor asks you to check your blood pressure, that's usually for like a focused period of time. We generally want that to be at least 7 days, 7 days of measurements. And we ask people to measure it in the morning and at night, because you can get fluctuations during the day. And your blood pressure will go up and down about 10 or 15 points in a typical day. So we ask people to measure it twice a day for 7 days at least. So that's like 14 different average measurements. And that will give your physician an idea, what your blood pressure is doing at home, and then be able to put you into those 4 categories. Like, are you really hypertensive at home, or is the blood pressure normal at home and only high in the office? Because if it's normal at home and high only in the office, you don't necessarily need to be treated, because your blood pressure is normal at home. You have white coat hypertension classically, and your outcomes are actually going to be fine without treatment. So again, it's the only way a physician's going to be able to figure that out is if you are able to do home blood pressure measurements. If you just rely on office-based measurements, you're going to overtreat people, because there's that 30-40% that their blood pressures do go up in the office.
Okay. So if someone is taking their blood pressure multiple times throughout the day and they see that variation, it's not necessarily just the average that you want reported. You want to hear what their blood pressure,
Yeah,
want
I
to see
think
how it varies.
you want to see a little varied, because it looks like it's always like low in the morning but high at night. Then you want to see, is there something going on at night? Are you eating like high salty meals? Are you, too much caffeine, or vice versa? If it's really high in the morning but okay at night, like, are you snoring? Is this a person with sleep apnea that needs to be treated? Are you waking up with a headache in the morning because, you didn't really dream well because, your body can't rest? So yes, I think given that variation can highlight some small differences, but overall, yeah, we also want to make sure we get a whole average and then treat that average at home.
Okay.
Yeah.
And there's a question about whether a condition such as essential tremors can cause high blood pressure.
Mm. Essential tremors, generally no. As some people get older, they do get a little bit of a tremor that can be treated sometimes with beta blockers. But that unto itself should not cause high blood pressure, no.
Okay. Okay, and there was a question that just came in on, is there a best time of day to take high blood pressure medication?
Yeah, that's a great question. I think some people vary a little bit. I've had some people that it's more effective at night. But most people, for most of the drugs, they are just once a day drugs. So, for instance, like hydrochlorothiazide or chlorothalidone are very common drugs, and that's just once a day. So if you're just taking one or two, I generally tell people just go ahead and take it in the morning, whatever's most consistent. You definitely want to take your medications at least 70-80% of the time. If people sometimes are on multiple medications, like 4, then and sometimes when they take them all at one time, their blood pressure does get a little bit too low. So those people, I may say, listen, take 2 in the morning, take 2 in the evening time, and try to space it out. But in terms of should you do it before or after breakfast, generally it's not going to make a big difference.
Okay, and if you're taking blood pressure medication, how long does it take to get the full benefit of those medications? Is that something that builds in the system over time?
Yeah, that's great. That's a great question. So each drug has something called a half-life. Like when you take a medication and you ingest it, it goes up in the bloodstream, and then there's a decay and it goes back down. And if you don't take another dose of it, it will eventually go down and down, down and disappear from the body. So that's called a half-life. And so most drugs have a half-life of about 12 to 18 hours. And so if you start a new medication, you need to take it at least 3 or 4 times before you achieve something called a steady state, where the blood levels have achieved a therapeutic level and doesn't vary too much. So, that's why some of my patients, they feel like, that like if they don't take their blood pressure med, like 2 hours later, the blood pressure spikes. It doesn't work like that. It's not like putting, water on a fire. After you've been on these drugs for a few days, generally you do achieve a steady state. There are a few drugs, which I don't know if anyone in the audience is on, like Hydralazine, which is a very short acting drug. And we kind of use it as a bridge, or in some people who have difficult to control blood pressures, and that drug has a very short half-life of like only like 4 or 5 hours. So that drug can wear off very quickly. But kind of your standard drugs like amlodipine, hydrochlorothiazide, lisinopril, losartan, valsartan, those are just dosed once a day. And so after you've been on it for like 4 or 5 days, you do achieve a steady state. So you shouldn't see so much of a variation in your blood pressure after that.
All right. And there's a question asking if your general doctor can do a coronary calcium test.
Yeah, they can. I mean, I really encourage all the primary care doctors to refer to me. Like, go ahead and order the calcium scores. Um, I think the knowledge level or the comfortability ordering it is varies by primary care, to be honest. So some primary care doctors would rather have the cardiologist, send the patient first for an evaluation, then have the cardiologist order it. Um, some of my referrers, I say, listen, order it, and if the tests are abnormal, then I'm happy to see those patients. So technically, anyone can order it. It's a very simple test. It is a CAT scan, and the heart is constantly beating, and so this is a CAT scan that is timed in between your heartbeats, and so it is a low dose radiation scan, but there is some radiation exposure associated with it. Actually, while we talk, I'm going to share you a screen shot of a calcium score. So hopefully you can, Mona, can you just see this, hopefully?
I can. And for those who are out there, if you can switch to speaker mode, or I think that's what it's called, you will see the slides larger.
Okay, great. So,
Yeah.
so this is a calcium score, and what you're seeing here is on the left, the heart in the middle, and you can see this white stuff. That's the calcium in the backbone. So this is a thoracic vertebrae, and then here in the front, you see this white here. This is the ribs, and so the calcium score is looking for calcification. It lights up very easily on a CAT scan. And you look in the heart here in the middle, and it's just all gray. There's no white. So this person has a 0 score. So this person has no evidence of atherosclerosis, and we can tell that this person with a 0 score, kind of no matter what age they are for the next 5 years, sometimes 8 years, is at very low risk of any heart attacks or dying from heart disease. So look at this person here, unfortunately, on the right. This is the heart in the middle, and you see this big white strip in the middle. That's calcium in the main artery of the heart. This is the left anterior descending artery, the LAD, which is also unfortunately known as the widowmaker, because this is the major artery that supplies the strongest part of the heart. And there's a lot of calcium in there. There's also, interestingly, a lot of calcium in the aorta. You see some calcium in the aorta valve here. So basically, the computer, it's a very computerized algorithm. It calculates the area of this white plaque, and then based on the area, you get a score. So anything above, 300 is really concerning, and this person's at 1200. So this person has a lot of coronary disease, and we see this, we make sure this person's not having chest pain. Many times we'll put this person on a stress test to be sure that with exercise, there's no bad blood flow, and make sure this person is taking aspirin and lowering the cholesterol with a statin medication. So that's what a calcium score is. Like, I think a great analogy, it's like the mammogram of the heart. Like women get mammograms to detect, to screen for breast cancer. It's not, mammograms aren't 100% accurate, but it's a cheap and quick, easy test to screen. This is what a calcium score is. It's a screening test to detect coronary plaque, heart plaque in the arteries. And many times we pick it up a lot sooner than any symptoms. And that's great because that means we have plenty of time to intervene, start the people on cholesterol reduction, make sure they take aspirin if it's high, if a lot of plaque, and then and also make sure that if they have high blood pressure that it's well controlled at that point. So if if many people in the audience, if you've never heard of a calcium score, you can certainly look it up online. There's a lot of literature on it. And most places it's relatively cheap. Just advertise. There's this place called Insight Radiology in Fairfax that charges about $120 for it. There is a radiology group owned by Johns Hopkins in Bethesda that charges 75. So for those living on the Maryland side, you can certainly utilize that one. Unfortunately, at this stage, most insurances don't cover this screening test. I predict in about 5 years or so, insurances will cover it because the data behind it is so predictive and so good. And but currently, it is an out-of-pocket expense. But I think it's nominal because certainly if you screen 0 on that and you avoid having to take an extra cholesterol medication, the cost savings will pay for itself in a year or two. So it's a great test. I'm not ready to say everybody over the age of 40 should get it, but maybe in a couple of years I may make such a strong statement. So
Okay.
yeah.
One question was, is it bad to have a diastolic over 90? And maybe you could go into why.
Yeah, so there are two numbers as we talked about, systolic and diastolic. Systolic blood pressure basically represents the max amount of blood pressure being generated by your heart during a heartbeat. The diastolic pressure is basically telling you what's the blood pressure left in the arteries during the resting phase of the heartbeat in between contractions. And generally, we want to keep the diastolic less than 90. A very typical blood pressure be 120 over 80. That being said, when you look to see which number is more predictive of heart events, systolic or diastolic, it's actually systolic is more predictive. So I would say, like, if you have high systolic and high diastolic, then you definitely need treatment. If you have a controlled systolic and your diastolic is a little bit above 90, you maybe will sit tight and just see if that gets better over time. But yes, if you've waited and your blood pressure is consistently over 90 and you have a normal systolic, then yes, you should be treated as well.
All right. And then can you comment more about the relationship between high blood pressure and dementia and cognitive decline?
Yeah, I mean, I think like we're still trying to investigate that because certain dementias like Alzheimer's is due to plaques. We can actually see plaques in the brain. There's other things like Lewy body disease or can cause dementia too. But most people with cognitive decline and kind of what we call, senile dementia, we believe is linked to progressive damage of the blood flow to the brain over time, and that high blood pressure basically increases pressure in your major arteries, but it increases the pressure in the small little capillaries that perfuse your brain too. And what happens over time is because those small little capillaries are seeing a lot of pressure, they start getting thickened. The walls start getting thickened because they're trying to protect itself from bursting, and over time, like, that causes actually shrinkage of those capillaries. And so sometimes when we scan people's brains and when they're over 70 or 80, we do see, everyone's brain unfortunately does shrink with age, but we can also see more volume loss in that in people who have high blood pressure. And with that volume loss over time, those people have more risk of cognitive and memory problems as well.
Okay. Um, and then can medical procedures such as angioplasty or the use of stents help reduce blood pressure?
Yeah. Yeah, that's a great question. m- Most stents and angioplasties really refer to ballooning or opening a blockage in an artery. So if you're doing that and you're stenting the coronary arteries, no, you're not really going to affect the blood pressure. If you have, as I said earlier, some people develop blockages in the kidneys the kidneys are perfused by two arteries, renal arteries. And if you do develop blockages in the kidney arteries and you open them up, then you can reduce blood pressure. That's not a super common situation. Out of 100 people with high blood pressure, maybe only one or two of them have blockages in the kidneys. And again, we look for that in the younger people, the people who have early high blood pressure. In older folks, generally you don't see that as much. So to your answer, technically yes. If the person has a blockage in the kidney renal artery, then yes, angioplasty or stenting would help there, but not in the coronary arteries, which are for the heart.
All right. And once you start taking high blood pressure medications, is there ever a point where you can discontinue the medications?
Yeah, absolutely. There are definitely folks with lifestyle changes can come off blood pressure medications. And, I have a great patient of mine. He's a great guy. He's a very successful businessman, but very obese. I mean, he weighed more than 330 pounds. And he made the decision to undergo bariatric surgery. So he had a gastric bypass. And he lost a tremendous amount of weight. And because of that weight loss, he was able to come off his diabetes medications. He was able to come off his blood pressure medications. And he's a new person. I mean, he exercises all the time now. And he's a great guy, and he chided me a little bit. He came in my office after the surgery, after it was so successful, and he said, "Doc, why didn't you make me do this years ago?" Because I mean, he had a fabulous result, and because of that, his life really has changed. So that's an extreme example of someone that with a lot of weight loss due to surgery can come off blood pressure medications, which we see. But I think for people who just are able to lose weight on their own through diet and more exercise, you certainly get better blood pressure control. And so if you're on multiple drugs, you can either decrease the dose of that or maybe come off one or two of them, depending on how much weight you lose. So yes. So yes, in concept, you definitely can control your blood pressure if you let things go and you're carrying a few extra pounds that you shouldn't, and you're able to lose that, then your blood pressure will definitely come down.
Okay. And then if you are being treated for high blood pressure, how often should you be taking your blood pressure?
Well, I think if it's been stable, I would tell my patients maybe once a week if it's really stable. So it depends how long you've achieved that stability. If you're in the initial diagnosis phase and your physicians are still trying to understand how bad your blood pressure is at home, then I would say at least a week of intensive measurement twice a day. So I think that's good. And then unfortunately, there are some people who are still in the labile. And to be honest, some people probably overcheck and they get a little anxious when they see their blood pressure. So for some people, I don't think you should be checking it 5 times a day. So I think if you're stable, maybe once a week. If you're early in the course, then some intensive monitoring with the supervision of your physician to help, titrate your medications. And if for some reason you're in a period of instability, maybe you had a recent surgery or a car accident, or you're in a lot of pain, then maybe once a day during those periods.
All right. Well, I think I have read all of the questions that have been submitted. Nobody has yet been brave enough to raise their hand and be unmiked, but Dr.
Yeah,
Tran is a very approachable person.
absolutely. Yeah.
Um, if somebody either that or I don't think I missed anything because Chump is here checking me to make sure I'm honest.
Okay.
But that was, I mean, a great bunch of questions.
Yeah, absolutely. These are really great questions, and high blood pressure is so common and kind of like very basic, but you can get into very complex situations, and there's a lot of variability out there. So I definitely want to emphasize there's no one size fits all, and I think for you to be treated correctly, make sure you have good monitoring at home and have a good machine at home. And obviously if you have signed on to this, you're on the alert and enlightened part of people, and you're taking blood pressure seriously, so that's good. But for if you have friends or family that are really ignoring their blood pressure, please counsel them and advocate that, they need to get their blood pressure in control, to save the heart, the brain, and the rest of their body from the kind of progressive damage of high blood pressure. Back in I think it was the 70s when it was coined the silent killer. And it is true, most people don't feel bad with high blood pressure and they can just live with it for a while and kind of ignore it. But unfortunately, this is something that will always catch up to people, and we want to help our friends and family attend to it before something bad happens.
All right. We did have another question come in about, would you recommend a blood pressure monitoring system that sends your blood pressure readings to a service and notifies your doctor when your blood pressure is out of range?
There are some devices like that that's usually monitored. Sometimes people, when they get discharged from the hospital, will send them home with something called like a commander, and it basically automates and it checks your blood pressure, heart rate, and weight every day. And those go to a service, and a visiting nurse will monitor that. Medicare is allowing something called RPM, remote patient monitoring, for blood pressure. To be honest, our group hasn't really utilized these services. There are some commercial companies that will do that. Of course, usually that incurs a charge against Medicare and then subsequently a copay required from the patient. But I don't have a specific company just because we ourselves haven't really utilized those services very much, but they definitely exist out there. So maybe you can talk to your physician about RPM. It's called remote patient monitoring for blood pressure. So it's out there for sure.
All right. All right. Well,
All right.
we'll wait. We'll pause just a moment to see if anybody has any other questions to put in there. Well, you're getting lots of thank yous, by the
Great.
way, in the chat.
Well, thank you for joining. This has been great. Yeah.
Yes, and Shampa put up in the chat to join us on Monday evening at 5:30. We have a talk about minimally invasive heart valve procedures. Some colleagues of Dr. Tran's, Dr. Sherwood, and
yeah.
Dr. Sarin are doing that presentation. That happens to be Heart Valve Disease Awareness Day. And you're getting lots more praise coming in. I hope you can see those. But
yeah, thank you.
Yeah, so thank you, Dr. Tran. I think we all learned a lot this evening, and definitely thank everyone for attending the webinar today. We do try to do these Ask the Experts regularly from Inova Heart and Vascular Institute. The past year, obviously, that was a bit disrupted, and this is actually just well, I guess we've done a couple this year, but we're trying to get back into a more regular schedule to bring you these programs. And once we sign off of the webinar today, once we close, you're going to see a survey that would be very helpful for us. If you would fill out the survey, it lets us know the types of topics that you'd like in the future. It gives Dr. Tran a rating, and that would be very helpful feedback. I think it's 9 questions, so hopefully if you will take the time to do that. And with that, on behalf of Inova, thank you for joining us. And thank you again, Dr. Tran. And I hope everyone has a great evening.
Great. Thank you, Mona, for that. And thank you, everyone, for logging on. It's been great. And as a party thing, I forgot to mention, people ask, like, what can I eat to lower my blood pressure? And I think 2 things. In the summertime, definitely eat a lot of watermelon. Watermelon has nitrates in it, and it can help reduce the blood pressure. And then during the winter months or otherwise, you can also drink beetroot juice. Cold pressed beetroot juice can lower the blood pressure. A lot of athletes actually use it to increase their exercise tolerance. So beetroot juice and watermelons are very helpful for that. So I'll leave with that parting thought, but it's been very enjoyable. I've really enjoyed all your questions. These have been really great things to discuss. And thank you again.
All right. Thank you.